We continue our lecture about laboratory examination during childhood. Here we talk about nitrogen metabolism. The liver is involved in the metabolic interconversion of amino acid and in the synthesis of non-essential amino acid. The liver senses most of the plasma protein including albumin, transferrin, complement and coagulation factor important in nitrogen metabolism through the urea cycle. Owing to the immaturity of urea cycle enzyme early in life, the level of ammonia in the plasma of neonate is highly elevated in the level than in its level in the 1 years old child. Persistently elevated ammonia level should alert the investigator to possible liver damage. So the nitrogen balance المتابعة أو القياس بتاع الأمونيا بيدينا indication لأنه ممكن يكون في liver damage during childhood. Number 4, which is examined or measured during childhood, is calcium and bone metabolism. Normal bone growth require integration of calcium, phosphate, and magnesium metabolism with endocrine regulation for vitamin D, parathyroid hormone, and calcitonin. The active of vitamin D is 125 dihydroxyvitamin D. Hydroxylation of vitamin D from diet take place in the liver and kidney and require normal functioning of these organ. واحدة من الحاجات اللي برضو مفروض نعمل لها متابعة أو investigation during childhood هي الإلكترولايت أو الكالسيوم أو البون مينرالز، كالسيوم فوسفات مغنيسيوم ومينلي the calcium. و these 3 electrolytes or minerals بيحصل لهم regulation عن طريق فيتامين دي والباراثايرويد هرمون and calcitonin. Hydroxylation of vitamin D from the diet take place in the liver and kidney and require normal functioning of this organ. The absorption of vitamin D required normally active parathyroid hormone. Secretion of parathyroid hormone in turn modulated by serum calcium and magnesium level where low level of both divalent cation inhibit parathyroid secretion. Approximately 98% of total body calcium is present in bone and less than 2% is measurable in the blood. Hypocalcemia. Hypocalcemia is defined as total serum calcium level below 7 mg per deciliter or ionized calcium below 3 mg per deciliter. In newborn, particularly immature, these levels may be commonly encountered with few symptoms like irritability, twitching, and seizure. Serum calcium is usually measured in children with seizure of unknown etiology. يبقى احنا مفروض دايما نعمل السيرم كالسيوم لانه السيرم كالسيوم بيعمل مشاكل كتيرة، فبنلقى انه الليفل بتاعت الكالسيوم اذا كانت اقل من 7 ملغ بير ديسيليتر والايونايز كالسيوم اقل من 3 this can lead to some symptoms like irritability, twitching and seizure. واي طفل بيعاني من seizure of unknown etiology بيحتاج انه نقيس له السيرم كالسيوم. والبرولونجد هايبوكالسيميا كان result in reduced bone growth and rickets بتؤدي ل ما يعرف بالريكتس. causes of hypocalcemia: prematurity, metabolic acidosis, vitamin D deficiency, liver disease, kidney disease, hypoparathyroidism, low calcium intake, high phosphorus intake, and hypomagnesemia. What is rickets? Rickets is disease caused by mineralization defect during bone formation resulting in increased osteoid, the unmineralized organic matrix of bone. Causes of rickets is vitamin D deficiency, inadequate exposure to sun, poor vitamin D diet and malabsorption, and organ resistance to vitamin D, phosphate depletion like in Fanconi syndrome. The biochemical finding: low serum calcium and phosphate, high serum alkaline phosphatase, and 25 hydroxy to assess vitamin D status. الأسباب اللي بتؤدي لظهور الريكتس هي إذا كان عندي deficiency في فيتامين دي نتيجة للتعرض لأي واحدة من الأسباب اللي بتؤدي لنقصان فيتامين دي اللي هو عدم التعرض الكافي لأشعة الشمس. الوجبات اللي بتحتوي على نسبة قليلة من فيتامين دي أو حتى المال absorption برضو ممكن يؤدي لنقصان فيتامين دي. بعض الأورجنز ممكن يحصل لها resistant to فيتامين دي بالتالي ما بيقدر يقوم بالنشاط بتاعه كما ينبغي phosphate depletion في حالة الفانكوني syndrome. Biochemical finding بنلقى دايما المريض اللي بيعاني من الريكيتس بيكون عنده low serum calcium and phosphate, high serum alkaline phosphatase and deficiency in vitamin D. الريكيتس ممكن يكون في منه نوعين. vitamin D dependent rickets type 1 is an inherited defect in 25 hydroxy vitamin D 1 alpha hydroxylase causing impaired formation of 125 hydroxy vitamin D, or vitamin D dependent rickets type 2 is an inherited disorder characterized by very high serum concentration of 125 hydroxy vitamin D. This syndrome is due to resistance of 125 hydroxy vitamin D secondary to defect in the 125 hydroxy vitamin D receptor. So the rickets is of two types, either deficiency of enzyme or resistance of the deficiency of vitamin D or the presence of vitamin D but resistance of its function due to deficiency or defect in the receptors. Hypercalcemia is defined as total serum calcium more than 11. This is usual in pediatric but potentially severe clinical implication. Patients with hypercalcemia have poor muscles tone, constipation, failure to sleep, and may develop kidney stone leading to renal failure. Number 5, which must examine during childhood, is endocrine function. Hypothalamic pituitary thyroid axis, primary hypothyroidism or congenital hypothyroidism result from any defects that cause failure of thyroid gland to synthesize and secrete thyroid hormone. Incidence is 1 over 4,000 pairs. Untreated patients with this condition have severe mental retardation with unusual facial feature. واحدة من المشاكل اللي بتحصل والمفروض الناس تعمل لها screening during a childhood هي الcongenital hypothyroidism، وهي من الأمراض النادرة لكن بتحصل. فدي الفيتشر بتاعة الطفل اللي هم بيكون عندهم يعني unusual facial feature due to congenital hypothyroidism. Treatment by thyroid replacement therapy is usually successful when diagnosis is established. بالتالي احنا مفروض نعرفها من بدري عشان ندي replacement therapy للثيرويد. The best diagnosis test is to measure serum TSH level, which is very high as a result of failure of long feedback loop between pituitary and thyroid. The thyroid hormone level is in untreated patient is very low. So hypothyroidism, congenital hypothyroidism, TSH is very high and thyroid hormone is very low. The only neonatal screening program is in Egypt. Screening secondary hypothyroidism, it is a result of pituitary failure to secrete TSH, which result in lack of thyroid gland stimulation and subsequent production of thyroid hormone. Here, the diagnosis is by low TSH. It is important to study other pituitary pathway to determine whether this is an isolated TSH defect or panhypothyroidism. محتاجين نشوف الأذر هرمون الثانية اللي بتتفرز من الباراثايرويد جلاند من البيوتيتري جلاند like البرولاكتين، FSH، ACTH، عشان ما نحدد إنه this is selective hypopituitarism lead to reduced TSH or panpituitarism that is result in low of all hormones in the pituitary gland. Also, we must screen or examine neonatal Graves' disease, the fetal thyroid pituitary axis function independently from the mother axis in most cases. However, the mother has very exciting Graves' disease. Here, autoantibody can cross the placenta and stimulate the fetal thyroid glands. The fetus can develop hyperthyroidism. Measurement of thyrotropin binding inhibitory immunoglobulin is usual for assessing risk of fetal or neonatal Graves' disease. هنا اللي بيحصل إنه الأم بيكون عندها Graves' disease والانتيبودي بيحصل لها كروس بريزنتال من المازر تو ذا بيبي. والميجرمنت اوف ثايروتروبين بايندينج انهبيتوري immunoglobulin هو effective in the diagnosis of congenital Graves' disease. Hypothalamic pituitary adrenal cortex, the most important disorder is congenital adrenal hyperplasia, CAH. Congenital absence of one or more synthetic enzymes that lead to cortisol and aldosterone biosynthesis. These lead to compensatory increase in ACTH, leading to stimulatory of steroid biosynthesis till the block point causing. Here is adrenal hyperplasia. Hyperplasia of the adrenal cortex, accumulation of intermediate compound proximal to the block, shunting of the substrate towards the adrenal androgen pathway. The most common disorder is 21 hydroxylase deficiency. Also, we can screen for growth factor. Growth hormone deficiency result in poor growth and sustained growth. When growth hormone act on its receptor on the liver secrete insulin growth factor 1 and it is binding protein IGF binding protein 3 due to diurnal and pulsatile pattern of growth hormone secretion. A single measurement is not sufficient to diagnose its deficiency. Insulin-induced hypoglycemia and clonidine-induced hypotension are common stimulatory tests used to detect growth hormone deficiency. Measurement of IGF-1 and IGF-BB3 is considered an effective tool for assessing growth hormone deficiency because their basal level do not have the great variations across for growth hormone. Infant with defect in these two factors, synthesis and secretion, are unlikely to respond to growth hormone replacement. That is all about laboratory examination during childhood. Thank you for good listening and see you in the next lecture.